Welcome everybody to this webinar. Hello to all the people that have joined us online and welcome. My name is Christy Watson and I am going to be chairing today's webinar with Dr Alison Gregory. I am a patron of the Royal College of Nursing Foundation and I am a full-time writer and part-time professor, but my background is in nursing, which is how I got involved with the Royal College of Nursing Foundation, which I'm sure you all know is a fantastic charity. They are an independent charity servicing and being focused on nurses, midwives, nursing associates, healthcare support workers, and student nurses and student midwives. And the Royal College of Nursing Foundation is independent. Their purpose is to strengthen and support nursing and midwifery to improve the health and well-being of the public. So I'm delighted to be here representing the RCN Foundation today. The RCN Foundation support people providing grants for hardship, education and research for every current and former nurse, midwife and healthcare support worker, as well as the students and nursing associates. And what the RCN Foundation has found is a growing trend over the past 4 years, consistent with the numbers of nursing and midwifery staff who have approached the RCN Foundation's benevolent service after fleeing situations of domestic abuse. While the sample is small, the percentage of staff experiencing domestic violence and abuse who received a hardship fund from us was around 2.5 times the national average. With this in mind, the RCN Foundation funded Dr Alison Gregory to carry out an exploratory study named, which it stands for, Nursing and Midwifery Professionals' Experience of Domestic Abuse. And the study has explored the domestic abuse experience and support needs of nurses, midwives and healthcare support workers across the UK. We will be hearing from Alison today about this incredible and important research and her findings as well as next steps. Nurses and midwives and healthcare support workers are more likely to experience domestic abuse than the general population and rarely feel able to seek support. Almost 90% of survivors working in healthcare say they face barriers to disclosure to seek help at work, with the available support lacking visibility and being limited to short-term practical help. So I'm sure you'll appreciate just how vital Dr. Alison Gregory's work is. Because of the nature of the discussion today and the research findings, please take care of yourselves, take a break if you need to, step away if you need to, and support is available to you. All the support details are on the RCN Foundation's website, and we will remind you of this as we talk today. So I'm very, very, very honoured and delighted to introduce Alison Gregory. Alison is an internationally recognised academic, an honorary senior research fellow at the University of Bristol. Alison has researched domestic and sexual violence and abuse for almost 20 years, with specific interests around the informal support provided by friends, family members, colleagues and neighbours, and more latterly on the domestic abuse experiences of people working in health and social care roles. Alison is also a counsellor and has worked for many years with trauma survivors. Today, we're focusing on domestic abuse experiences of people working in nursing roles, and Alison will be sharing some initial findings from the named study. That study, again, is the Nursing and Midwifery Professional Experiences of Domestic Abuse. So I'm delighted now to hand over to Dr. Alison Gregory. Thank you, Alison.
Thank you so much, Christy. And welcome, everybody. I wish I could see you all and meet you all in person. However, I'm really pleased that so many of you have been able to join us online today. As Christy has said, the initial part of this webinar, the presentation, we'll be doing that part first and then taking a break. And this part will be recorded, but we won't be recording the Q&A section, but you can watch the recording of the presentation at a later point, or you can direct colleagues to that. As Christy has said, I'm Alison Gregory, and as a researcher, I've been focused for the past 8 years or so on researching the domestic abuse experiences of people working in health and social care roles, and that's what I'll be talking about today. And I'm currently working on the NAMED project with the Royal College of Nursing Foundation, which I'll talk about a little bit later in the presentation. But I'll start with some background from some previous studies. However, first, as Christy has said, and this is really important, I'm going to give a content warning before we continue. I will be sharing some information in the form of facts, figures, and also quite a lot of quotes that you may find difficult. So please do take care of yourself, particularly if you have in any way been affected by domestic abuse. If you need to stop listening or to pause and come back to the webinar at a later time, that's absolutely fine. Okay, so as I start the presentation today, I'm going to make sure we all have a foundational understanding about domestic abuse. We've got a very broad audience today, so I want to lay the groundwork for the rest of the presentation with you. So let me begin with a definition. Domestic abuse is controlling, coercive, threatening, degrading, and violent behaviour by a partner, an ex-partner, or adult family member. Domestic abuse can include, but is not limited to, coercive control, psychological and emotional abuse, physical violence and abuse, sexual violence and abuse, financial and economic abuse, harassment and stalking, and online or digital abuse. And I want to mention that some definitions talk about incidents in relation to domestic abuse, but this can be really unhelpful for victim survivors because domestic abuse is more of an entangling web of behaviours. It's often patterned and repeated, it may be daily or continual in nature, and so many of the behaviours are subtle yet cumulative. So the idea of incidents doesn't necessarily make sense to people who are experiencing them. And whilst I have met maybe one or two victim survivors who have experienced a single abusive event, that is very much a rarity. I've also highlighted a couple of things on the screen that I just want to mention. First, I've highlighted ex-partners because abuse often continues after the end of a relationship, particularly if the people have children together, and this is a time when victim survivors are most at risk of serious harm. The second is coercive control. What do we mean by this? It's a pattern of intimidation, degradation, isolation, and control with the use or threat of physical or sexual violence or punishment of some kind. Now, I appreciate that reading text like this doesn't necessarily help us to envisage what abuse looks like in the context of someone's life. So the next slide contains some amalgamated quotes. They are anonymised. I've given some names, but they're not people's real names. But these quotes are from nurses, midwives, and healthcare support workers who've experienced domestic abuse, and really I'm sharing this to help us grasp the reality of the abuse they are experiencing. I ended up with broken ribs and a fractured ankle from being pushed backwards. There was also strangulation, hitting, hair pulling, and threats to pour hot coffee over me. My ex-boyfriend smashed up my flat because he was jealous about the close relationship I had with my friends. He threatened me several times. I'm taking the children away from you. You'll never see them again. I'm going to burn the house down with you all in it. I've got my spies out on you. The kids hate you. Taking and picking me up from work, putting me down so I felt worthless and not capable. Controlling my food and then would feed me. Used to give me certain looks in public to shut me down. Slated me in front of others, especially around food. Forced cannabis onto me. I would wake up in the night and he would be having sex with me without my consent. He threatened to send intimate pictures to all my work colleagues. My mother was also a nurse in a different hospital. She rang my manager and told them that I was stealing drugs from the ward. The investigation showed no drugs were missing. They started demanding money and would take items from my home to sell or just take my bank card. They talked me into taking out a loan for £25,000, which was only in my name. He threw my uniform over the back garden wall into the neighbour's yard and then called my boss to say I was mentally unwell. So this begins to show us in more detail not only what domestic abuse looks like, but also the situations in which nursing employees who are experiencing abuse are showing up for their shifts and about what they're facing, when they leave work to go home. Okay, my slide won't go forward, but thank you. How many people in the UK experience domestic abuse during their lifetime? Well, the recent statistics indicate that we are talking about just under a third of women and around 1 in 6 men. So that's a huge proportion. We also know that in the UK, around 100 women per year are killed by a partner, an ex-partner or a family member. And for men, the figure is around 25 domestic homicides per year. And of course, as you can imagine, these figures are underestimates. So domestic abuse is common, it's dangerous, it's also really harmful for people's health and well-being, including, of course, physical injuries, but also all sorts of elevated risks of physical health conditions, including chronic pain, neurological symptoms, cardiovascular problems, gastrointestinal disorders, and the list goes on, unfortunately. We know that people's mental health is also affected with hugely increased likelihoods of anxiety, depression, post-traumatic stress disorder, suicidal thoughts and actions, and self-harm behaviours. But let's move on to think about who experiences domestic abuse. And this is where we encounter myths and stereotypes which unfortunately persist and which the news and the media tend to reinforce. And I think the myths and stereotypes come about because, like any other difficult issue or difficult topic, we're really uncomfortable with the idea that domestic abuse happens to people like us. Believing it happens to other people is a defence mechanism to stop us feeling worried, to help us feel somewhat safe living in the world. But the downside of this means we're much less likely to notice when it's happening to the people around us. The truth is anyone can experience domestic abuse, people from any country, any sex, gender, ethnicity, sexuality, background, class, race, culture, faith, status or financial position. It may take slightly different forms depending on people's socio-demographic characteristics, but anyone can experience domestic abuse. Now, there are 2 characteristics that put people at a higher risk. The first is being a woman. As you saw from the statistics on the previous slide, the prevalences of domestic abuse are higher for women, though the prevalence for men is not low. The second characteristic which puts people at higher risk is being young. Adults under 30 are more likely to be victims of abuse from a partner. Okay, so hopefully I've convinced you that anyone can experience domestic abuse, but what about healthcare professionals? Next slide, please. And specifically, what about nurses, midwives and healthcare support workers? These are questions that my colleague, Dr. Sandy Deenser, and I set out to answer. Increasingly, as we were conducting research with patients, with service users in healthcare contexts, we were getting disclosures from healthcare employees to the point where it really began to concern us. And I think it's fair to say that understandably, a great deal of research in the UK and subsequent interventions and strategising have focused on healthcare responses to domestic abuse, about equipping and supporting healthcare professionals to respond to patients and service users who are experiencing abuse. This is a great idea. Victim survivors tell us that they trust healthcare professionals, and if they're going to make a disclosure to a professional, it would most likely be someone working in a health or social care role. But in the midst of this, there's been very little focus on healthcare professionals themselves. And it was really interesting to me to see the following quote recently in a Nursing Times article. And actually they were talking about nursing education, but it feels like the authors have also appreciated the issue that Sandy and I have been grappling with. So where did we begin? Well, we collated and analysed the relevant research from across the world as part of a literature review. And we found that 42% of female healthcare employees experience lifetime domestic abuse, and around 15% of male healthcare employees, with around 10% of healthcare professionals experiencing abuse in the past year. So thinking about my local trust, I live in Bristol, it's North Bristol NHS Trust. They employ around 4,000 staff. So that's 400 staff members currently experiencing domestic abuse, just in that one trust. It's 400 people attending every day for their shift, having experienced abuse by a partner, an ex, or by a family member. And surveys of nurses by Cavell and midwives by the RCM indicate much higher prevalences for nurses and midwives in the UK than in the general population. Some of the research we looked at indicated impacts on people's work, with victim survivors feeling that they were less able to work to the best of their ability, but also a recognition that when people had had personal experiences of domestic abuse, that they were more likely to identify and respond to patients. We also found that healthcare professionals faced unique barriers to help seeking, which I'll talk about more later on. Next slide, please. Clearly, this picture is cause for concern. So our next study, the Pressure Study, told us a bit more. The Pressure Study was an online survey and interviews with people working in primary and community-based healthcare roles. So that did include nurses, but also doctors, allied health professionals, healthcare support workers, dental staff, pharmacists, and opticians. And I'm just going to share some of the most pertinent of the findings today from that particular study. If you'd like to read more, Sandy and I have published several papers about the research findings. So let's start with the survey and think about the impacts of domestic abuse in people's workplaces and the responses that victim survivors received and the impacts on patient care. Next slide, please. And our first finding was that abusers actively behaved in ways or used tactics that would impact people's abilities to get to work, to be ready for work, to concentrate at work, and lateness to work and sickness absences were common. And in terms of patient care, most people who completed the survey told us they did encounter patients experiencing domestic abuse, and for 40% this was a regular occurrence. And the vast majority felt that their personal experiences had affected their ability to respond well to victim survivors. In particular, they felt that they were probably better at spotting the subtleties of abuse. But on the downside, this could take a toll on the healthcare professional, and they could find themselves feeling upset by the interactions. Next slide, please. And thinking about support in the workplace, the existence of domestic abuse policies for employees was patchy, and when they were in place, there was often limited visibility and implementation. And how about the support people received? Well, they reported really mixed responses. Some people's colleagues had offered positive support and good responses, including compassion and offers of practical assistance. Some victim survivors had not intended to make a disclosure at work. It was sometimes because a crisis necessitated telling someone, or the disclosure was taken out of a victim survivor's hands because colleagues had either witnessed the abuse or the abuser had involved their workplace in some way. There were some very well-meaning responses that were not ideal, but also victim survivors reported actions or lack of action by senior colleagues which were blaming, unkind, or even dangerous. And what about the interviews? Next slide, please. These are the four main themes that I'd like to mention. I'll explain each of the themes in turn, giving you some illustrative quotes. Next slide, please. So starting with cognitive dissonance. And what I mean by this is a disconnection or inconsistency in how healthcare professionals thought about abuse. In particular, they struggled to identify and accept their own experiences as abuse, even when they could see that if what was happening to them, if what was happening to one of their patients, if that disclosure had happened, they would be very concerned about them, but they couldn't quite see it from their own perspective. For example, this participant said, "I wouldn't have even called it abuse if the therapist hadn't pointed it out to me." She said, "So everything you've just described, if a patient described it to you, what would you have called it?" Then I started crying because to say the words that it's domestic abuse, it was really hard. And linked very closely with this cognitive dissonance is the sense of identity that healthcare professionals carried and what this identity meant both to them and to other people. So just a couple of quotes to illustrate. "I thought that it just wasn't meant to happen to you. It was something that happened to other people but didn't happen to you. And people think you're a professional and it doesn't happen to people like you. So even when it does, you feel like it's not allowed to happen to you." And people gave us examples where their professional status had been used against them by other professionals as they tried to seek help and support. For example, people had tried to disclose to colleagues and experienced their shock or disbelief or judgment. Some of them had encountered specialist workers, specialist domestic abuse workers, who had assumed that they had a lot of agency or treated them harshly or tried to kind of rush them through their decision making. Some of them had encountered social workers or police officers who made assumptions about domestic abuse not happening to healthcare professionals. And 2 of the participants had encountered judges who were really unhelpful. One who told a mental health nurse that it was her role and duty as a healthcare professional to keep the abuser on the straight and narrow, and another who told a healthcare professional that essentially she must be lying about experiencing domestic abuse because as a healthcare professional she would have known better. So you can see just how difficult this healthcare professional identity is, both for people themselves and also when confronted with other people's prejudices and misassumptions. And moving on to the third theme about how it feels as someone who has experienced domestic abuse to receive related training in your workplace. Many people really welcomed the training they received. They felt validated and encouraged by the fact that it was given priority in their workplace. However, it wasn't always an easy or comfortable experience. I remember sitting in a lunchtime lecture and it was about domestic abuse. I was sat on the front row. I almost threw up. To see it in black and white, you're like, oh yes, tick that box, tick that box, tick that box. And it wasn't necessarily about what was being presented from the front by the trainers, but perhaps more crucially, some of the negative impacts people described were the side conversations with colleagues alongside the training. Next slide, please. Thank you. And finally, from the Precious study, if we think about the additional challenges healthcare professionals face in reaching out for help, people said over and over that healthcare professionals shouldn't experience abuse, that they should be superhuman, they shouldn't have any needs of their own, making it really hard for people to reach out for help with a common sense of expressed shame. Some of the other challenges people described were the practicalities of working in healthcare, which made it difficult to have the time and space to reach out for support. People had concerns about existing relationships with colleagues or with services that they referred to being affected. People were often unclear how their workplace could support them and whether there was any help or a policy in place. Almost everybody we spoke to indicated they had some concerns about confidentiality and anonymity. They worried that if the abuser was also a healthcare professional, that they would be able to access any information that they disclosed. They worried that their colleagues might snoop into their medical records. They worried that their fitness to practice might be called into question. And they expressed concerns about what it meant to bump into one of their patients or service users whilst trying to access specialist support. And actually none of those were concerns were unfounded. People gave us examples where those things had happened. We also heard in people's narratives a lot of medicalised explanations and excusing of abusers' behaviour, and as healthcare professionals, a strong impetus to try to fix or heal the person. And finally, because many of the participants worked with patients who had experienced domestic abuse, it was almost like they knew too much about what the potential negative outcomes from help seeking might be. Next slide, please. So this brings us up to date with the NAMED study. The NAMED study is funded by the Royal College of Nursing Foundation, and I'd like to thank the donors who provided the finance to make this research possible. And the study is specifically focused on the domestic abuse experiences of nurses, midwives, and healthcare support workers. The aim of the research is to create greater recognition of the issue, to make tangible recommendations for action, and to ensure that people in nursing roles who are experiencing domestic abuse get the help and support they need. And why focus on this nursing staff group particularly? Well, they make up considerably over 50% of the roles in health and social care, both within and outside of the NHS. And we're talking about 1 million people across the UK. So for the NAMED study, we ran a survey last summer, and it was completed by 204 nurses, midwives and healthcare support workers working across the 4 nations of the UK. And then we've conducted a further 20 in-depth interviews, and once the analysis is complete, we'll be working with key stakeholders and with victim survivors to develop a framework for implementation of recommendations. And today I'll mostly be talking about the survey findings. We've got a lot of data to work with, so these are just initial findings. But I want to thank the people who took part in the survey and the interviews. They were incredibly generous with their responses. The data set is unusually complete. We gave people an option not to answer every single question, but actually people completed the vast majority of questions. They also gave us a lot of very detailed information, which in itself tells us something about the need for nursing employees' experiences to be heard, for people to have opportunities to talk, to describe their experiences. And many people thanked us for conducting the research. There was a real sense of gratefulness that actually this was something people were talking about, and also a very real sense of altruism, with people desperately wanting their own experiences to change the situation for other victim survivors in health and social care professions. Next slide, please. So let me start by giving you some information about who completed the survey. As I mentioned, we had 204 UK respondents in nursing roles, and 96% of these were biological women. The vast majority of participants were aged between 36 and 65, 82% were white British, and 88% were heterosexual. And 23% indicated that they experienced some form of disability, and people talked in the free text about physical disabilities, challenges with mobility and pain, poor physical and mental health, and a variety of forms of neurodivergence. And many people expressed that the disability that they had described was either exacerbated by or as a direct result of the abuse they had experienced. Next slide, please. Thank you. And thinking about their nursing roles, most had worked in England or in Scotland in health and social care roles, with fewer working in Wales and Northern Ireland. Several people had worked in multiple countries in nursing roles, both within and outside of the UK. 93% of survey respondents were currently working in health and social care, and they were a very experienced group of practitioners, with over half having worked for at least 20 years in nursing roles. Most had primarily worked in healthcare roles rather than social care roles, and the most common working environments that people mentioned to us were NHS secondary care, hospitals and community hospitals, GP practices, and other types of NHS service, with many people having worked in multiple environments over their career. 91% had worked as a nurse, 5% as midwives, 21% as healthcare support workers and healthcare assistants, and 8% in other roles. This, of course, adds up to more than 100% because around 1 in 5 people had worked in multiple roles over their career. So that gives you the context around who completed the survey. But what did they tell us about the abuse they had experienced? Next slide, please. Well, as you can see, the figures are high. Almost every person who completed the survey had experienced some form of psychological or emotional abuse. And for over a third of respondents, this form of abuse was recent or current. Around 3/4 had experienced forms of physical abuse, forms of economic abuse. And again, with the economic abuse, for many people, this was recent or ongoing. And over half had experienced sexual violence and abuse from a partner or adult family members, and this proportion is high in terms of routine victim survivor report. And for 6% of respondents, the abusive situation or relationship was current, but for a further 42%, whilst most of their experiences were in the past, they were still experiencing abusive and controlling behaviours from the abuser. And if it was their ex, this was usually because there was ongoing contact because of court or divorce proceedings, or because they had children together. We also asked about particular tactics that abusers used in relation to people's job roles. And on the screen, you can see the most frequently reported behaviours. So they included contacting the victim survivor multiple times during their shift, including contacting them via the ward or work phone, and knowing that it wasn't possible for them to respond, but still expecting them to do so, or there would be punishment or consequences. They also included stopping the victim survivor from sleeping or sleeping well before their shift, making it difficult for them to attend work feeling rested and energised. They accused the victim survivor of having relationships with colleagues, with patients, with service users and residents. They reneged on childcare arrangements, often last minute, and made threats regarding the children's safety or the children's care, which made it extremely hard for people to leave for work. Sometimes they stopped the victim survivor from pursuing their career, and that could be in a variety of different ways. Or they made it deliberately difficult for a victim survivor to actually get to work in time for their shift, or they interacted with the victim survivor's colleagues in inappropriate, threatening, or abusive ways. And on the next slide, I'm going to share some quotes which describe what this looks like in practice. So the calls and texts throughout the shift and being angry if I didn't answer straight away despite knowing why I couldn't. Calls during work accusing me of not being at work and then demanding I took photos of my workplace to send to him. If I didn't respond within a 2-minute time frame, he would accuse me of cheating. They'd want me to sit up with them during the night, mostly to have sex, which they said they were entitled to. I would be so tired the next day. He will sometimes keep me awake late at night by talking to me about stressful matters when I need to sleep. He would wake me up at 2 a.m. to discuss my poor behaviour. She accused me of sleeping with colleagues on several occasions. He would refuse to take my child to school if I did a night shift, so I had to choose between getting my child to school and leaving work without finishing notes. Constantly interrupting me during my academic studies because I wasn't doing housework, childcare, whilst I was supposed to be on study leave. Encouraged me to put off applications for promotion through manipulative language and persistence. He encouraged me to withdraw from a higher banded job role I had applied for. He would say the car is for him and would make me take public transport even if it was raining or snowing, or he would make the decision last minute and I'd be late for work. Work colleagues avoided interacting with me and became distant, as he would threaten them with physical violence if they spoke to me. So you can begin to appreciate how the abuse people were experiencing in the home environment or outside of work was tipping over into their experience of work and affecting their relationships with colleagues and their career. Next slide, please. And you may be interested in who the perpetrators of the abuse were, given that we used a definition which includes partner abuse and abuse from adult family members. And these percentages again add up to over 100% because 1 in 4 of the respondents reported abuse by multiple people, including by multiple partners or multiple family members. So in terms of an overall summary, 94% of survey completers reported abuse by a partner, and they may have experienced abuse by both male and female partners. And 26% of people reported abuse by a family member, again with this significant overlap of experiences. Around 17% of respondents reported that the abuser also worked in a healthcare role, most commonly as a nurse, doctor, an allied health professional, or as a paramedic. And this, as you can imagine, often made things additionally challenging for people. Next slide, please. So for the 34 respondents who talked about 35 abusers working in healthcare roles, they indicated that often work was no escape because they worked in close proximity or had colleagues in common. Sometimes the abuser was in a managerial role or had another form of profession-based power or authority over their role. For example, the abuse perpetrator was a consultant in a clinic where they were working as a nurse. So these are just a few examples. She tries to take control when I'm ill and belittle the doctors I see and tells me not to have the tests and scans my doctor ordered. They tried to intimidate me, saying my behaviour was medically weird if I wasn't acting as they wanted. My ex would perpetrate coercive and controlling behaviour overtly in front of colleagues and management. On occasion, he would physically and sexually assault me in the workplace. If I made a sound, other staff and patients may have heard. He used his knowledge of restraint techniques to physically control me. He accessed my phone number through the staff phone book and started messaging me. He said he would report me to my line manager and make allegations of drug errors, and he would also report it to the Nursing Midwifery Council. And the common examples that people gave us related to the abuser using their health knowledge or position to intimidate or falsely diagnose, or using their connections or position to try to discredit the victim survivor, or making false allegations or threatening to report them to their professional regulator, to their manager, to the police. So as you can see, the situation where both the victim survivor and the abuser are healthcare professionals, there can be forms of abuse that are profession related, and the work is not the safe space that victim survivors so often describe to us. Next slide, please. And if we zoom back out again now and look at all the people who completed the survey, whether or not the abuse perpetrator worked in health or social care roles, how was the situation and people's experiences of abuse impacting on their ability to work at their best? Well, you can see that the vast majority of survey respondents indicated that their ability to concentrate at work and their confidence in doing their job were affected. And around half of respondents felt they were slower at work, that they sometimes struggled to remember their work tasks, and that they weren't taking up the opportunities that they might to enhance their career, including things like attending for training or going for promotions. Almost 2 out of every 5 participants said they felt triggered at work. So 87% had encountered patients, residents or service users who were experiencing domestic abuse or coercive control. And whilst the majority felt their experiences to be an asset in terms of being more vigilant, more attuned to signs of abuse, particularly the more subtle forms of abuse, and people felt that they were more able to respond with an enhanced level of empathy and perhaps direct people towards the support options available, actually the experience of supporting a victim survivor or encountering an abuser could also be very triggering and potentially distressing for people. Next slide, please. And continuing to think about work-related impacts, around 2/3 indicated that the abuse had resulted in them taking some time off work. And when we asked about the longest block of time people had been off work, 1/3 had been absent for a month or more, including 7% who had been off work for more than 6 months as a direct result of the abuse and its impacts. But it's important to mention that presenteeism was also apparent, where people attended for work even though they actually needed to not be there. And this was either because the abuser wouldn't allow them to take time off, or because it wasn't safe for them to remain in the home, or because the workplace had made it very clear that it would be an issue if they didn't attend for work, or because work was somewhere that they could temporarily forget what was happening at home. So for all of these different reasons, they overrode their physical and mental health needs. And the common reasons people took off sick were because of physical injuries and consequent ill health, periods of poor mental health, exhaustion and feeling that they were unable to do their job safely, needing to be at home to keep their children safe, leaving or ending the abusive relationship, and for court cases and custody battles. So these people said, I had to take some time off due to bruising and marks that could be seen, for example, black eyes and burn marks on my arms. My ex-husband fractured a bone in my hand and I was given a sick note for 1 month from A&E. I had severe UTIs from constantly having to have sex and I was working all day. I felt embarrassed to speak to my colleagues, so I went home. This became severe and I ended up with a kidney infection. I had to take 3 episodes of sick leave due to stress and anxiety. I took several days after getting no sleep, being kept awake at night. I would not have been safe undertaking tasks at work. I needed regular time off work to keep my child safe. I would ring and say I felt unwell or had D&V, even though I didn't. I took a block of time off work when I had to move out of the marital home to my parents' home in order to keep myself and my children safe. I took more than 2 months off as my partner used the family court to take custody of our child as revenge for reporting a physical assault to the police. Next slide, please. And around 1 in 5 of survey respondents had left a job, a role, or even the profession as a result of the abuse they had experienced, or the ongoing impacts, or for safety reasons, or because their workplace and managers really hadn't understood the situation or had responded very poorly. I had to move back to my hometown as my ex-wife was continuously threatening me. I loved that job, but I couldn't cope with the demands of a management role with what was happening at home. I ended up resigning after 12 months through ill health. I'm thinking of leaving my nursing career behind to get away from my current employer, as my abuser remains there. The only way to escape the abusive relationship was to resign my job. I moved out of area and got a job elsewhere. At first I had to reduce my hours, and then I had to go to a different county in a women's refuge. I went to work in an area where he had no control. The stress he put me through meant my sickness record was awful. I'd be too exhausted, on edge and depressed to go to work. And it ultimately cost me my job. I had to resign because they were going to sack me. I lost my job due to this. I was given the golden handshake. It was humiliating and not indicative of me, but I couldn't tell them. The shame is real. Thankfully, most people hadn't left their nursing careers and nursing profession. However, it was definitely a consideration for many people. Next slide, please. So in addition to work-related impacts, we also asked more generally about how people's experiences of abuse had impacted their lives, in particular their health and well-being. And 2/3 said their physical health had suffered. Almost all said there had been mental health impacts, and almost 90% said that they had experienced periods as a result of the abuse where they had felt hopeless, desperate, or couldn't see a way forward. And for all these different types of impact, it was clear from the free text that some of the impacts were ongoing, were continuous, or were likely to be felt lifelong or have devastating or life-altering impacts for people. And within an already difficult survey, we very carefully asked some questions about people's self-harming behaviour and thoughts and actions towards ending their life, with 1/3 of survey respondents telling us that they had overused or misused alcohol, drugs, or prescription medications, and around 1 in 4 had used self-harming behaviours such as cutting, burning, or pinching themselves, and 1 in 4 had engaged in risky behaviours where they were likely to get hurt. They also told us in the free text about actively withdrawing socially and isolating themselves, and about problematic eating behaviours. And with regards to suicide, more than half of the participants indicated that they had experienced suicidal thoughts. 1 in 5 had at some point made active plans for suicide, and 1 out of every 8 respondents had attempted suicide, including someone who had very nearly jumped out of a window at work. So clearly, as a result of domestic abuse, these are nursing employees who are mostly finding ways to continue to turn up at work, to continue to offer care and support to patients and service users, whilst experiencing huge impacts and at times enormous distress. Next slide, please. So moving on to thinking about people's help seeking at work, well, only 2 out of every 5 survey respondents told us that they had attempted to make a disclosure or help seek in their workplace. And sadly, even when people did reach out, they often felt disbelieved by their colleagues, their managers, or the organisation. And there were a lot of perceived barriers to help seeking that nurses, midwives, and healthcare support workers described, with the most common being a sense that they should keep what was happening at home or outside of work separate and distinct from their work, and worrying that people would judge them, blame them for the abuse, would think less of them, including around their professional standing, their abilities, and fitness to do their job. Next slide, please. And actually, people's perceptions of barriers were not inaccurate. People gave us examples where their concerns or the concerns of other participants were realised. Because we deal with safeguarding and domestic abuse, I thought I'd get a good response. But after the poor response I got, I worried that people would judge or blame me, especially after my manager put it on the intranet. From then on, I stopped trusting people and felt my work and home were going to be separate. When the abuse was happening, my manager told a friend who abused my trust by telling other nurses. They all acted differently towards me. This was in a negative way. I was often ostracised on shifts. I was blamed in one instance when I started talking about what was happening to me in my marriage. I was reprimanded by my manager for being upset at work and talking to one of the doctors. They labelled me mentally unstable at work, and my boss informed many of my colleagues that I was mentally unwell during that period of my life. It felt like confiding at work belittled my status in the team. I felt like I shouldn't be experiencing something I support families with. Because I was a nurse, I felt I should be able to help myself. It's my job to help others. So I felt I should be able to help myself. The barriers were me. And as you can see, some of the barriers are very much external, and some of them are related to an internal sense of who domestic abuse does and doesn't happen to, and in particular the idea that people in nursing professions should not experience abuse. And actually, beyond the barriers mentioned, the free text indicated to us that some of the responses in workplaces were much worse still, with managers and colleagues effectively ignoring overt signs of abuse, minimising the abuse, being unsympathetic, blaming the victim survivor, not understanding the significance of what they were seeing or what was happening, or only focusing on the impact at work or on the team, on the workplace, and as a result, employing punitive measures, or making the situation less safe, colluding with the abuser, or additionally abusing the victim survivor. That's obviously quite a negative picture. However, thankfully, some people did get positive responses at work that really made all the difference. Next slide, please. And this is where I'll begin to draw my slides to a close, because I do also want to highlight the positives, that doing something to help and support a colleague need not be difficult or complex. Invariably, it involves noticing what may be happening or any signs of abuse or its impacts, that something is wrong. It can include believing people and acknowledging their experiences, giving them time and space for action, and knowing what's available, both within or outside of the organisation, in order to direct a colleague to the support they may need, and offering people genuine concern, compassion, empathy, and a very real sense of what it is to be human. So these people said, I had a huge bump on my head when my partner had hit me. The sister said, did he do that? I said, yes. She gave me a big hug and said I would be safe working there. I felt loved and held. The specialist domestic abuse nurse recognised that him contacting the police was one of the malicious actions done by abusers, and she initiated processes and gave information on how to protect myself. My work colleagues supported me most, telling me to take time off when I needed it and they would cover. They got a domestic abuse independent advisor who was in the ED to come and talk to me. The advisor supported me to leave the relationship, and work gave me time off as sickness leave. I discussed with my supervisor at the time that I needed to flee my home. They referred me to Oki Health for support around accessing counselling. I was given the contact details of the IDVA in our hospital after I called my manager to inform her that my partner had been arrested. My line manager has been a fantastically supportive and valued friend. I also have received continuing support and space to talk from a couple of other super supportive colleagues who've been invaluable to me. My line manager was amazing, talked to me, made sure I was aware of the services available, and checked in on me. I will never forget her kindness. So you can see that when colleagues and managers got it right, they got it really right. And actually, none of the things they did were especially complex. Next slide, please. There's so much more I could say, but we want to make sure that we have enough time for discussion and your questions. Do be entering your questions, anything you'd like to ask. So before I hand back to Christy and we then go for a comfort break, I'll finish with a few suggested next steps for anyone who's been motivated by what I've shared so far. If you haven't already, do undertake some domestic abuse training or take a look at some of the amazing resources online. I've recently helped to create Safe Spaces. The link is on the slide. This is a free training resource to help employers and also individuals to create safe and supportive workplaces for employees impacted by domestic abuse. It contains lots of dramas and interviews. It's very interactive. Do also find out about the specialist support services nationally and in your local area. If you're not sure where to start, take a look at the knowmore.org directory. Do find out if your workplace or organisation has a policy or guidance around domestic abuse, and specifically around staff members experiencing abuse. Quite often workplaces have policies around what to do if a patient or a service user is experiencing domestic abuse, but not necessarily around employees. Also, some workplaces have access to counselling, to employee assistance programmes, and to all sorts of other forms of support for victim survivors. So make sure you're aware. Do keep an eye out at work. Ask your colleagues how they are, whether they'd like your support. And at the bottom of the slide, I've included a resource I wrote for Women's Aid. It's really the nuts and bolts of getting started with asking and receiving disclosures, and how to keep the conversation going, and how to offer informal support, not only to colleagues but to friends and family too. It's a really practical guide and includes how you can remain supported yourself as you're offering that support to someone else. And advocate for change. There is an NHS template for policies, and some trusts and organisations have really gone the extra mile in terms of making explicit the processes and support that victim survivors can expect in their workplaces. I know I've covered a lot of very difficult material quite rapidly, so I'm now going to hand back to Christy, and then we'll be taking a break.
Thank you very much. The next slide, please. Alison, that was a lot of harrowing information, but such important research. Again, if you need to take a break, if you need to take a step back and come back to the webinar at any point, then you can do. One of the examples that you gave at the end of good management was that one of the people who was survivor of domestic abuse felt loved and held. And here at the RCN Foundation, we believe that anybody experiencing domestic abuse in our profession deserves to feel loved and held. And so I am really, really pleased to be announcing that the RCN Foundation is today announcing a domestic abuse fund, which is going to provide hardship grants to survivors of domestic abuse. And it's open to applications from all nurses, nursing associates, midwives, and healthcare support workers, anyone who is experiencing or has experienced domestic abuse, and all the details will be available on the RCN Foundation website. Just to say, you do not need to be an RCN member to access this hardship grant, and we really hope that it will help many, many people. And so next steps is going to be much about putting this very, very harrowing but essential and important research into practice and action. Thank you everybody for listening. There is a QR code on the screen at the moment which you can scan if you want more details about the Hardship Fund, or again go to the RCN Foundation website.